going to begin the recording. All right. Hello, everybody. Thank you so much for joining us today for the LMCH Health Status webinar. I'm really excited to kick you off on this next piece of needs assessment process. Just a reminder again before we get started to please put your phones on mute, but please do not put your phone on hold because then we hear the background music. So thank you for keeping that in mind. So welcome. We have several folks here in the room today. Carrie Terry is with us in spirit only. She's not here in the room, but we do have Trudy Esch and Robin Osborne from MDHHS. This is Julia Heaney from MPHI, and I'm joined by Lauren Lapine and Aaron Madden. Today we will be going over steps 4 and 5, specifically the maternal and child health status assessment. But as we have before, we'll begin with kind of an overview of the needs assessment process, and we'll close out today with a review of next steps. But we are going to be talking about all kinds of data today. That will be the large bulk of our conversations, really focusing on data that you'll be provided and data that you'll have available to you for completing this assessment. Just a reminder, this is the process that we're in the midst of. You've organized for success, you've engaged your partners, and you've completed a visioning process. Most of you have provided your documentation of the completion of those steps. We are in the process of reviewing what you provided, and we'll be sending back feedback. Largely just some things for you to keep in mind, things that we noticed as we looked at the documentation that you provided, things that we think really stands out as special about what you've done, and some opportunities for you, we think, to build on what you've completed already. So we'll be sending out those feedback forms beginning next week, and they'll come your way just as soon as we can get them done and out the door to you. So the steps we're in right now are gathering assessment information and interpreting assessment data. After that, you'll be using all of that data to identify strategic issues, develop goals and objectives, and then develop strategies and build action plans. Another reminder, the timeline of our assessments. Within steps 4 and 5 of this cycle that we're in the midst of, there are 3 types of assessments. You are already underway with community themes and strengths. That was covered on February 14th's webinar. If you missed that webinar, you can find it on the SharePoint site. Just hop on there and you can watch the recording or listen to the recording. We are going to be covering today the maternal and child health status assessment. And this is the assessment that really focuses a lot, as I said, on quantitative data about health within your community. And the last assessment that we'll talk about is a maternal child health status assessment. That'll be covered on March 29th. And really an assessment of the capacity of your maternal child health system to deliver essential maternal child health services. This is going to be really important to our discussion today because it's really the way that we've organized the measures that we are going to be providing to you to look at to understand health status within your community. So this is a life course model, and the life course model really emphasizes that the outcomes that we see later in life are based on experiences and exposures earlier in life, that health is not something that happens just at one point in time, it's something that's created over time and even between generations. So we're keeping that sort of concept in mind of understanding health from a life course perspective as we're looking at these static measures of health within each phase of the life course. We'll be really looking at this today and thinking about measurement from this perspective today. We're really used to looking at measures of health outcomes and health behaviors. We're used to looking at measures of cardiovascular disease, rates of smoking, that type of thing. But we all know that when we see those outcomes are based in what's happening within the service system within your community, as well as the social determinants of health within your community. So this pyramid is a visual of that sort of idea, that the health behaviors and health outcomes that we see are reflective in part of the environment in which people live, work, and play. as well as the nature of sort of the systems for protecting and promote health within our state and within our country. So before we jump into the next piece of our assessment, we wanted to check in with everybody and hear a little bit about how your community themes and strengths assessments are unfolding, and to answer any questions you might have about that piece of the process today. So we're going to unmute all of the lines and welcome you to ask any questions that you might have. Really excited that we unmuted and we're not hearing any music, which is saying to me that everyone has remembered to not put their lines on hold. So thank you for that. But please jump in. Any questions you have or any observations that you've taken away from the work that you've done so far with community themes and strengths? Your voice. I certainly understand your hesitation. Like I said last time, I'm nervous to talk in front of the 73 people we have online today too. So I appreciate the hesitation to jump and ask a question or share your experience. But if anyone's willing to just tell us a little about how it's going, I think the group would love to hear about that.
Hi, this is Barb from Kent County Health Department. And
hi, Barb.
Hi, how starting these input words. We've decided to call them walls because that does resonate with some of our people here. So community vision boards, and we're going to be putting them in our public health clinics. They are going to be manned by an intern who will try to engage some of our patients, clients that are coming into our clinics. We've also expanded those boards to a couple conferences involving male and fathers. I have a group at one of them, and planning to do the full voice. Too. We're preparing for that as another way of measuring our strengths and weaknesses in the community.
That's awesome. Thank you for sharing, Barb.
You bet.
I'm willing to tell us a little bit about where you are with the assessment. That I can understand the hesitation, so I think we'll move forward. But if anything comes up to you during our conversation today about either assessments, of course, jump in and ask questions, and we'll certainly have time for questions at the end. Okay, so the maternal and child health status assessment is where we are in this process now. So this is really all about pulling together measures of population health and determining what they tell you about your community. So what you'll be looking for is disparities in those population health measures by race, ethnicity, gender, income, or other factors, as well as health issues where your community is facing outcomes that are more troubling if you compare them with the state, if you compare with other counties, if you compare them with national standards. Within the data that we provide, these are the types of comparisons that you'll be able to make. You might be able to make additional types of comparisons based on data that you might have available at your health department or that your partners might have available. For example, some districts or intermediate school districts are able to provide information that's broken down in fairly small geographic areas, or you might have zip code level or even census block level information in cases, and so you're welcome to break down your data in additional ways, but these are the types of ways you'll be able to break down the data that we share. So our goal in thinking about how to set up this assessment, as with all of the assessment work that we'll be doing with to make it scalable. So we really use the life course framework and the pyramid concept. And we've actually identified hundreds of measures that could potentially be used to understand maternal and child health from a life course framework. Of course, hundreds of measures isn't something that that most of us can kind of think through and walk through in a reasonable period of time to make good informed decisions. So we took that large list and we scaled it back, focused down on a set of measures that reflect the life course and reflect those multiple levels of measurement that you see in the pyramid. We focus largely on data, on measures where data are available at both the state level and the county or LHD level. There are a few exceptions to that that we'll highlight as we go through data that we'll be providing shortly. At minimum, what we're asking you to do is review the data that we send to you, that we provide to you, and take away lessons learned for your community from that. However, if you want to expand, you can. If you want to look at additional measures, if you want to look at additional population groups, pull in other data sources, pull local data that you have available, you are more than welcome to do that through this process. What we're trying to do is provide a reasonable, realistic starting point for looking at maternal and child health status within your community, and sort of provide a framework that you could build from. One thing I wanted to mention that's on this slide is that all of the state Title V performance measures are included. This is those exceptions to having state and local data available on all of those measures. A couple of the state Title V performance measures come from PRAMS, for example, which is available at the state level, but it's not available at the local level. However, we know that some communities have PRAMS surveys that they do or have similar data collected for some subset of your population. So we still included those, especially because they're Title V performance measures and because you might have local data that you could look at. One thing I'd like to mention up front about the data is that the state level data we're providing includes demographic breakdowns wherever that type of breakdown was possible. We don't have those same kind of demographic breakdowns for the local level data, which is a limitation, and again, an opportunity to expand what we're providing if you have the time and space to do that. Bullet point, just to emphasize again, you are more than welcome to include local data and additional measures as you see fit, as that makes sense for your community. So what we'll be providing is 2 Excel spreadsheets that are populated with the majority of the data that you will need. We'll lock the spreadsheets for editing just so that by mistake cells aren't deleted or changed on accident. The 2 we're providing are a spreadsheet with state data, and that spreadsheet is where you'll see those demographic breakdowns, and then we'll provide a county data spreadsheet. And that spreadsheet includes data that are for your county or your health department, or in some cases, the region that you're in within the state. Within the tool is a table 6, that includes several sources of population data. These were sources that were used to populate the 2 spreadsheets. And if there are other data points that you want to add, this is a place to look for ideas as to where you might be able to find data that you might want to use to supplement what we're able to provide. Okay. A little about how the spreadsheets that we'll be sending are set up. Within each spreadsheet, you're going to see 6 tabs across the bottom that mirror the levels of the pyramid. There'll be a tab in the front for demographics. So you'll see a tab for demographics, health outcomes, health behaviors, community health, direct and enabling services, and public health services and systems. Each of those is a separate sheet within the Excel file, and in a minute we'll pull it up and actually click through it so you can see how that works. So within each of the tabs, you'll see a list of measures, including their data source, And the measures are organized along each phase of the life course. Those phases of the life course are color-coded in accordance with what you see on the screen. There are measures associated with each of those phases of the life course where that was possible. I think one of the interesting things about looking at measures in this way is that you can see pretty clearly where there are gaps in our surveillance and epi sort of systems that have. You'll see lots of places where we don't have particularly strong measures around childhood, for example, and middle childhood is a place where we have a gap in data generally. And you'll see that in looking at the way the data are set up. I did this slide because there are just a couple measures that were available only by prosperity region. And so just in case you weren't familiar with the prosperity regions or how to find yourself within the prosperity region, we're including this as a resource. Also along those lines, one of the sources of data that we're using is WIC, and because some communities have WIC providers in addition to what the provider at the health department, you'll see those other providers also at the end of the spreadsheet so that you have that complete picture of WIC data within your community. Okay, diving in a little bit more deeply into the state data table. Demographics are listed across the top of the table. And you'll see gray in cells where we aren't able to provide the demographic breakdown in that particular way, or where it doesn't make sense to provide the demographic breakdown in that particular way. So we have measures that are specific to women, for example, so of course we wouldn't break down gender for a variable like that. It's only possible to do this where there's a sample size large enough and where the data are collected in such a way that you can provide demographic breakdowns. So the cells that are grayed out are areas where those demographic breakdowns couldn't be provided, and otherwise the data appear under the demographic category that you see along the top of the page. Again, you can see how the phases of the life course are color-coded in the left-hand column. You can see the pyramid along the bottom. So county level data, you see that this looks very similar, except for across the top, instead of demographics, you see the geographic breakdown. So the county, the health department, or the prosperity region, or the WIC provider. One thing about this is that we included the health, if you are in a multi-county health department, we included the data for your health department in alphabetically the first county that is included within your district or regional health department. So at this point, we will switch over to the actual spreadsheets and look at this in just a little bit more detail. And as we do this, that we are very, very grateful to the epidemiologists at the state that did the massive amount of work it took to pull these data at the state and local level, both in terms of the time to actually pull together the data, but also the thinking and strategizing that they did around how to get the data at as local a level as is possible. Of course, there's data sources that can't be pulled at the local level, but for many of our data sources, if they did multi-year averages, did a slightly larger geographic area, they were able to pull together something that's more local than the state data. So we're very grateful for the expertise and the time that they took to work through that. This is the state Excel file. And so what you see here is the demographic information for the United States as a whole and for Michigan. And the intent of this is to give you a sense of how Michigan compares to the country as a whole. And you'll see this replicated for at the county level in the other spreadsheet in just a minute. So the health outcomes tab, so again, we're in Excel, and so the levels of the pyramid are organized in the tabs along the bottom of the Excel file. So each of these is a different page within your Excel file. Then the indicators are, or the measures are listed along the left-hand column, the second one in, along the phases of the life course, which are in that first column and color-coded. So we go through each of the measures themselves. As you receive these spreadsheets and if you have questions about the measures, what they mean, what's included, how they're calculated, anything like that, please just reach out to us and we will either answer or we'll get you an answer from the EPI staff so that you know what you're looking at. In order to try to help in that way, we have the data source listed as well as the year or multi-year average that are reflected in the data. As you scroll over on the spreadsheet, you can see the demographic breakdowns that are able to be provided. So we have age, we have race, ethnicity, gender, in some cases grade or level of education, level of income in some cases. So we're looking at this spreadsheet and kind of exploring at the state level what these indicators look like from a demographic perspective. We'd ask you to think about what the demographic profile of your community looks like, how it looks in relationship to the state, and to use this as a starting point for understanding disparities within these measures of health at the state level, as a kind of a starting point for looking at what they might be like at the community level. Provide maybe an idea of where you might want to focus a deeper dive into looking at particular measures. We're going to click now along the bottom. The next tab includes our health behaviors, our measures of health behaviors. We have our community health measures, services measures, and our health services and systems measures. As we go, there are a few more gaps in the data that are available. Some of these data points won't be available at the state level. They don't make sense at the state level. They only make sense at the local level, but they're still appearing here. Some of them we're still working on collecting and hope to provide some supplemental information by the time we start sending these out next week. If we begin sending out these tables before we be fully populated, we will of course send additional data as they come in to us.
Should we double check if anybody has any questions?
Yeah, absolutely. Let's pause there and see if anyone has questions. Just give us a second to unmute. Okay, they're unmuted. Do you have questions so far about what we've shared? Does that include the state rates also? It does. In just a second. Any questions at this point? Okay, so the local file. There it is. Okay, so this is the file for the Northern Michigan Public Health Alliance. The health departments in the north part of the state are completing this assessment together as a region, which is great and makes a lot of sense for how they work together. So all of their county data are included in this spreadsheet. The data that we send for each of you will include only the the counties within your service area. So if you're a single county health department, it'll only include your county. If you're a multi-county health department, it'll include each of the counties within your service area. Of these regional groups that are working together on their assessment. The tab again is provide demographic information, followed by health outcomes. So let's go there. And can you zoom in just a little bit? Okay. So at that first indicator, the percent of women aged 20 to 44 reporting their general health as fair or poor. You'll see that we have the data source again here. The BRFS is the data source. And we have 2 years that are combined to create the local estimate for this particular. What we have in the next column is the Michigan total, so that gives you a point of comparison. And then the next column, we have the Michigan county with the highest value. By, if applicable, the Healthy People 2020 target. So the reason we're giving all of these points of comparison is that as for some counties within the state, you'll frequently be above the state average. So the state average isn't as important a point of comparison for some counties. And for you, you might want to look at the Michigan county with the highest value or how close you are to the Healthy People target as just another way of sort of informing your decisions about opportunities for making improvement. Another way that you can, if you're a multi-county health department or completing this as a region, the other opportunity you have for making comparisons is looking at differences by health department or differences by county. You can see in this tab we have a lot of counties and a lot of health departments that are represented in these particular data. We go to one of the measures that has that health department data but not county data.
The BRFS stuff on this one does. So is there a measure? Not the example has prosperity region if you want to show that too.
Okay. Oh, thank you for that. That's good.
It's on the far right.
That first measure, it couldn't be calculated at the county level. It couldn't be calculated at the health department level because of sample size, but it does have it calculated at the prosperity region level.
Any of the BRFS.
So, similarly, some of the indicators are available for health departments, but not for counties. And you see what that looks like. So, you got, let's see, benzene-leelanol, and for this percent of adults who were ever told they had hypertension, you can see benzene-leelanol's value in the Benzie county column, and then you can see for the ones that are in that kind of beige color, where the data for that health department are included. Yeah, can set up. So let's flip to health behaviors. They are set up in a way that's similar to state spreadsheet, but here health behaviors, you'll see a couple of measures that are not available at the through a state level data source. Can you zoom in just a little bit?
Yep.
Can't quite read it.
All right.
Thank you. So the percent of infants put to sleep without objects in their crib, bassinet, pack, or pack and play. This is a state performance measure, and it's available at the state level through PRAMS, the Pregnancy Risk Assessment Monitoring System. If you have local data that align with this measure, then you could include that here. If you don't, and we know many of you won't, then you won't have any local data to look at. Unfortunately, for this measure, it's a gap. But we wanted to include it just in case you did have data on this measure, and because it is a Title V performance measure, we thought it was important to include. Can you go to the YRBS MiFi measures? Okay.
Let me zoom in.
Zoom in a little bit. Thank you. Okay, the students who could ask their mom or dad for help with personal problems. So this is a data point that's available through the MyFi, but the MyFi can't be calculated at the state level. It's really a local level data source, and we'll dive in a little bit on how to do that later. So for these data that are available at the local level, but not state level, we didn't include anything, but we will provide you with some information about how to get access to those data if you want to look at that measure. Like the state tab, through direct and enabling services, public health services, you'll see for the data that were available at the state and county level for your community, and then where there are some gaps where we're asking you to pull local data if you have access to it, if you can pull it. The public health services and systems area is one where there are a lot of gaps, and it's difficult even to come up with measures that make sense at the state and local level for public health services and systems, which is one of the driving forces behind having a separate system assessment that will be complete as our third assessment. But this is, we thought it was important to include measures at this level because we know that the way that our public health services and systems function is a driver of health outcomes, and we don't want to sort of neglect that fact in the way that we're thinking about measurement. And we think that it highlights some interesting things that might not immediately come to mind as an area, as an opportunity for improvement at the local level. So, for example, there's a measure in here about the % of workplaces that have lactation policies. That might be something that some health departments have explored this type of measure in the past. Might be something where you want to focus in on your largest workplaces, or where you might want to have a partnership with a group that's really focused on lactation within your community to explore this a little bit more. But we do want you to think about what you could measure, or what measures are available that tell you something about how your service system is functioning, in addition to telling you about how healthy your people are. Okay, so we'll unmute the lines and pause here for questions. I know this is a lot to take in, and I know that you'll have a lot to explore and ask questions about when you see the data yourselves, but are there questions that you have right now?
Renee from Chippewa. So looking at this graph, we submit our data. I'm looking at the northern region that you've got there with the names of the different cities. UP being one region, when data is all together, will be compared with LMS, Marquette, all the Upper Peninsula as a region. Is it going to be a regional dispersion then? And then if the needs in Chippewa are different than the needs, say, in the western UP, is it going to be determinate of need and then we all follow it?
Good question, and I think that we'll answer that in a little more depth in a minute. But what you'll be doing as you look through these spreadsheets is you'll be noticing each place where you find opportunity for improvement. So that could be in one county where you have lower rates of breastfeeding, another county where you have higher rates of smoking, another county where you have opportunity for improvement around teen pregnancy. It could be a variety of different things and will be a variety of different things that you notice about health status within and across all of the counties that you're looking at and service areas you're looking at. You'll be basically creating sort of a catalog of all of those things that really stick out to you as important health issues for your service area, for your region in the case of Northern. And you'll use that as one source of information to make decisions about what set of priorities you might want to tackle through a collaborative planning process. So you're absolutely right that you will see diversity in what needs are most present in what parts of a service area, and you could have a very long list of what those needs are, and it'll be up to sort of the next pieces of this process to figure out within that long list of needs shared priorities across a health department or across a region.
Thank you.
And that is that the northern region of 21 counties actually asked us to compile their data together in the 21 county public health alliance, and they're working together collaboratively. So they specifically asked if they could do that work together, and we do know that in the UP that there's a UP collab going on, but we weren't asked specifically to break down, to only report the data by the UP. So like Chippewa you'll get your own data, and each of the other health departments up there will get their own data, LMS, Marquette, Dickinson, Western UP, and I'm sure I forgot somebody, so I apologize in advance because I think I covered everybody, but I feel like I missed somebody. So in any case, we're reporting your data separately unless you direct us in a different way.
Yeah, and so this is Ray over at Western UP. If I could jump in real quick also. Most of the indicators that you guys are getting for us are available at the county level, whether it's low birth weight or percent prenatal smoking or whatever it happens to be. A few of the things from the state behavioral risk factor surveying are only available on a 3-year running average per health district level. So Chippewa being a single county health district, again, they'll get a lot of county-specific data on that. A few of the behavioral risk factor survey data, because of the fewer people that are surveyed, even over 3-year running average in UP, if it's a question that's focused on less than the whole adult population, for instance, it might be just men in a certain age group that had a certain health screening. So now you've got an even smaller group answering. Some are only given at the UP-wide level, but I think that you guys would agree that for 80–90% of the indicators you're going to send us, they're available at the county level.
Yeah, most of them are, and if not the county, at the health department level. But just as you said, that first indicator that we looked at, because it was specifically women in a certain age group, it was only available at a regional level in that case. So there are those exceptions, but largely the data that we're sharing are available at the county level. Any questions? Oh, so there are data sources that we'll be providing through another avenue. So as we've said, you'll receive the state spreadsheet, you'll receive a local spreadsheet that includes only data for your health department, or in the case of the regional area. And that will be one source of information for you to use for this assessment to identify strengths and gaps around each of those sort of layers of health. Lots of other opportunity to gather data on a variety of topics aside from what we'll be providing. And one of those really great data sources for the state is the MyFi. And this is the Michigan Profile for Healthy Youth, and it's the sort of local version of the YES, which is available at the state level. So we're going to go to the MyFi website quickly, and just to show you that it is pretty easy to, you want to Windows Explorer probably. Well, it works. Sometimes the pop-ups don't work very well. And so on the county reports, click on the link, and you'll select the survey cycle. They have the dates for the most recent, but there isn't any data in there yet. So if you go 2015 to 16, and select the MY, and select the county, or in counties, you can select Ingham County. That's where we are. see along the right-hand side a variety of tables come up. The MyFi is collected from high school students and middle school students. So the summary tables are broken down in that way for high school and middle school, and we can just do the top one. So you click on the report that you'd like, and then you just go down to generate reports, and oh, your fields work. Mine don't. When I'm in Rome. Okay, so the first piece that you see here is pretty important because what's important to understand about the MyFi is that it's collected at the building level, school building level, and it's totally voluntary. Schools can choose to do it or not do it, and it's anonymous at the building level, and of course at the building level and anonymous at the student level. So unless you have relationships with the schools within your community, you won't know who does and doesn't participate. So that creates a lot of variability in the utility of this data source across the state. For some communities, they have good participation, and it's a really solid source of data about health behaviors for middle and high school students. For others, they don't have great participation, and the strength of the data source is a little bit less. This first page, if you don't have those relationships to know kind of who's in and who's out, this page will give you kind of a sense of that. You can see build participation on this first tab, and then if you go to the second tab up at the top, you have a little bit of demographic information about actual participants. You have a sense of the degree to which this might be reflective of the county. So this tab it actually gives you the indicators with the questions from the survey along the left-hand side, and then the percent of students who responded affirmatively to that question along the columns. We have just a very small number of MyFi indicators that are within the spreadsheets that we'll send you. And so if you get into this source, if you decide that it is a good source for your community, you can add as many others as you like. There's tons of information in the MyFi about a variety of risk years for youth. And if you have a good response rate, then this is a really great data source to look at. And you can see it by grade level. You can see it by gender, broken down by race and ethnicity, and also by this last indicator of academic performance, was often really interesting to look at. You can see some huge differences in risk behaviors between kids with A's and B's and kids with D's and F's oftentimes. So that's one data source that we would suggest that you take a look at. This source is out of the USDA. It's about the food environment. And if you want to type in, oh, that's okay. Lansing, Michigan. You can see here, and if you click on all the boxes over there, you can see some information about the food environment in the area that we're sitting in right now. And you can zoom out maybe just a little bit to see and the left-hand side. Yep. Okay, so if you go to the key up there and click on the question marks, it gives you a little bit more information about the question next to the green and the orange and the, yeah. It gives you a little bit more information about what you're seeing. So where you see green, this is where our low-income census tracts where a significant number or share of residents is more than 1 mile or 10 miles from the nearest supermarket. So what these colors are displaying is for census tracts with low-income residents, how far those residents are from a supermarket. And as you go down, you can see how that changes. Color coding. If it went break. So this is a way to look at the food environment within your community. The change with this particular data source is that it's the data are a little bit dated, a little bit behind where we are right now, but still provide some interesting information from a geographic perspective, which when we're talking about the food environment, that's really a very logical way to think about that type of indicator. I encourage you to play around with that website a little bit and see what it tells you about your area. I'm going to to the presentation for just a second. A little bit about the supplemental data sources. So both the MiFi and the food environment have indicators that are listed on the spreadsheets that we'll be sharing. However, there's a variety of other data sources that you can look at that really that don't fit within the structure of those spreadsheets. And those supplemental data sources will be sent out by email when we send out the spreadsheets. We're going to show them quickly here as well. So this is going to go through, and I think we'll just jump right in. First additional source that we'll send is the regional MPINC score, and so these are scores of a hospital's degree of support for breastfeeding. And these scores are available at the regional level. You'll see when you see the report by prosperity region specifically. We'll all be sending WIC program data, and the WIC website also has a lot of data. I'm sure you have, of course, access to the data from your own WIC clinics as well that you can look at. But WIC collects really great detailed information about breastfeeding, initiation, duration, exclusivity, that could be very informative. So we'll send out this table along with the keys so you can see what agency number each of those agencies refers to. We'll be sending out maps on birthing hospital access in Michigan. One note on one of the maps, it doesn't include the birthing hospital in Tawas in Northwest Michigan. We'll say that again also when we send out this resource. In Northeast Michigan. Yeah, so we'll say again when we send this out, but this will give you a sense again for that last tab in the spreadsheet for public health services and systems where it's really hard to get good data. This will be a way to kind of look at the degree to which pregnant women in your community have access to a birthing hospital. The next we'll be sending out is the Michigan Family Planning Clinic Directory, again, just to kind of think about access to family planning services for folks within your service area. We'll be sending out updated PPOR analysis. Some of you have asked for that resource, and we'll send it your way. The concept of perinatal periods of risk and the data that you'll see when you get this certainly had to be explained to me a couple of times. And so if you have questions when you see this, don't hesitate to reach out so that we can provide a little bit more information about what you're looking at and what it means, how to interpret it, if this is something that you want to dive into and look at in more depth. Also, this other neat resource, which is an interactive map of opioid prescribing patterns. So we'll pull that up quickly so you can kind of see how it functions. Consider it might be something you want to take a look at. So the data in here are based on Medicare Part D prescribing. Pops up. You'll see it pops up at the level of the country, and you can find Michigan on there. But then you start to zoom in, switches to showing you county. In your county, you can see the can't say the word, opioid prescribing rate for that county specifically as compared with the state and the country. If you zoom in even further, you'll see zip codes pop up. And that's you really, really close there. I think it's okay. You can see how the that lowest zip code level is popping up in Pittsburgh. It functions in that same way where you can click on it and get that comparison information, and of course use the color coding of the map to kind of get a sense of where those rates of opioid prescribing are highest. So if this is an issue of concern within your service area, this might be a resource that you want to jump into and explore in a little bit more depth. Last one, there's information that we'll be that we'll be sending out on neonatal abstinence syndrome. It's a PowerPoint that describes rates of neonatal abstinence by region. We'll send it your way so you have that as a resource as well. Question you're asking yourself right now, and I'm going to try to give an answer to that question in just a minute. But before we get there, are there any questions or other resources that you want to make sure that your colleagues across the state are aware of? Well, we will answer this question. I know that if I were sitting in your shoes, and even here sitting in my shoes, looking at all of this, it can feel really overwhelming and like, where do I even start to explore all of the data that are available on maternal child health within my community and for the state. So we're going to suggest a fairly simple and straightforward process for taking a look at your data. Drawing some conclusions based on it. So what we suggest that you do is bring together your partners, and especially bring partners to the process who have some comfort with data, familiarity with these data sources. Of course, they'll be especially great resources as you dive into the data that you're looking at. We suggest that you set an agenda for your conversation together. With data, it can be very easy to get stuck. Around questions of what does this mean, is this correct, this is different than something else that I saw, and you can end up spending a lot of time on just a few data points. So we just suggest setting an agenda that helps you move through the levels and the tabs, and to have a parking lot for those really important questions and concerns that come up. So you're documenting those things, so you're having a plan to follow up on them, but you're not kind of getting bogged down too much in the details, and you're able to keep moving through the process. We also recommend that when you have this conversation, you have somebody in the room who can record the observations. They can type it right up on a laptop. We'd suggest that you use a complete sentence to record your observation and make sure you're noting the phase of the life course, the measure that led to the observation. One of the ways that we've done this, if you have, considering the volume that you'll be looking at and considering different levels of comfort in reviewing data, one of the things that we've done pretty frequently when we've facilitated this process is we bring together just the data folks or epidemiologists together to take kind of a first pass through everything and pull out those areas that are particularly striking, might be of particular concern, so that the group doesn't have to review every single data point, because that can be very overwhelming, but is instead focused on sort of a narrowed set from that first larger set that you have at your fingertips here. That can be one way to sort of focus the conversation and make it a little bit less overwhelming if you're able to kind of take that first pass at everything and pull out the high points before coming together to discuss. But we definitely would encourage you to bring together your partners and do this as a group. and engage them in this process of reviewing data. Different folks notice different things, different things stick to different people or mean things to different people, and people can interpret them in different ways. So it's good to have a group that looks at the data together. So if you're reviewing the data, we'd like you to notice a couple different things. We'd like you to notice disparities at the state level and do so considering what the demographic profile of your community looks like. If you're using MyFi data, if you have good MyFi data for your community, we would encourage you to use that local level, those local demographic differences as part of the conversation. Or if you have other local survey data, some of you have local BRFS and so forth, certainly bring those into the process where you can to look more at disparities at the local level. We'd like to identify measures where your health department's or your county's value is lower than the state. That could be a signal that that might be something that you want to pull out. If you're part of a district health department or if you're working as a region, we suggest that you notice which kind have lower values for particular indicators. If you are in a health department where your county's values are largely higher than the state, we would suggest that you notice places where your county is falling short of a national target, like the Healthy People targets we included, or where there's a sort of a gap between where you're performing and where the highest performing value is. When you're going through this process, you'll largely be noting opportunities for improvement. However, there's, of course, strengths as well and health successes across the state, and those are an important part of your story as well. So make note of those things that are strengths and successes within your community. We'd like you to think about, as you go through this process, gaps in the data. What aren't you learning about? What do you have a sense is important for your community, but it's not really reflected in the data that you have at your disposal? Those can point to opportunity to use qualitative methods to gather more information, program data to gather more information. Any data set that you're looking at is going to have gaps, things that you're not seeing, and where you are noticing something about health in your population where there isn't a data source. That's not a good reason, of course, to not look at it in more depth and think about how you can tackle that question in a different way. You get to the point where you are actually reviewing data and you're ready to start filling in the tool itself. You'll answer a couple questions. We'd like to learn about any process that you used to gather your own data. If you took that step, resources you used, what other data sources you incorporated into the process. We'd like to know about the data gaps that you encountered. At the state level, folks are always thinking about that question of what are our really important data gaps and what opportunities do we have to fill those gaps. And so that information coming from all of your experience will be really helpful. And we'll also, of course, like to know how you address gaps in data to the extent that you were able to do that. Then Table 7, you will summarize your key findings. So as I described, this conversation having that we'd suggest you have with your partners, the sort of bulleted list of findings that you note with your partners, this is where you will where you'll document those observations. So you'll write a complete sentence for each finding. Note the phase of the life course reflected in the finding and the measure or data that you used to inform that finding. And on the next slide, we have an example of what that might look like. So we state finding in a sentence like this: African American women in Michigan are more likely to report that their health is fair or poor. 33% of our county's population is African American. Phase of the life course is reflected, pre and interconception care, and what data informed this finding. State level BFS, the percent of African American women between 20 and 44 reporting their general health was fair or poor. The end of this is to make sure that you have a good catalog of all of your key observations that came out of the process that you went through with your partners. And when you've completed all three of these assessments, you will have a very comprehensive set of findings that will, in the next part of the process, talk through how to look at together and make sense of sort of the bigger picture of what all of these things tell you. At this step, all we really want you to do is observe what's in your data and make note of it. We're going to unmute again and ask if you'd be willing to share a little bit about your experiences completing assessments of this nature. Have you participated in a community health status assessment before? And can you tell us a little bit about your experiences? Share with your colleagues some of your lessons learned, takeaways, processes you use that you found helpful, anything of that nature. And you are really experienced with this type of assessment activity.
This is Laura Bauman from Washtenaw County.
Hi.
I'm just thinking about, the years as we've done big kind of data retreats with partners and done things like that. I think kind of that idea of having a framework with which people can look at the data, and in Washtenaw County, we're always very aware of many times our overall county measure looks better than the state average, not for everything, but for many things. But within our county, when you start coming by race or by gender or by economic status or educational status, that's when those inequities and disparities emerge. So learned with, working with community partners, it's really helpful to already have that framework set up and to help kind of guide people to look for, okay, look at the overall rate, but sure, let's start cutting across these areas where, and using that health equity lens to find we can focus more work.
I think that's a really important recommendation to the group. Thank you. Have you learned through your experiences doing this? I really like the phrasing of a data retreat, by the way. Sounds fun. What sort of data do you use to look at disparities at the local level?
Hi, this is Ray again over at Western UP. We've done a couple rounds with our hospital partners and some other healthcare partners in 5 counties. In 2012 and 2015, we did a regional health needs assessment, and we even did our own random household address sampling for a MOUT version that aligned with the CDC Behavioral Risk Factor Survey. And so we get the data, get back in our, well, last time we did it for 6 counties, but 2 of our counties we combined, so we had 5 population frames, and we had about 1,800 respondents, so we had about 400 per county level, so we could do county level estimates for each indicator, like, access to health care, do you smoke, all the standard questions, about 70 indicators. So we're able to break out and do reasonable estimates with narrow confidence intervals at the county level, but then to look at disparities, we then recombine the data so that we pull it out, we can get rates with estimates within different groups. So we get gender, groups, household income, and educational attainment levels. And so we find out, being not in as much of a racial and ethnic diverse area, except for our Native American populations in a couple counties, but we find great disparities in health status and access to care and health outcomes and behaviors in socioeconomic levels. So we find really striking, for instance, say on say tobacco use, for instance, if your household income's over $50,000, or if you have a college degree, your tobacco use rate might be like 10%, but if you're low income or didn't finish high school, it might be 35%. So for all those indicators, we're able to compare across the income levels and the education levels and see these really disparate outcomes.
The survey has been a really great resource to kind of point you toward the populations most in need of support and services within your health department.
Absolutely, and it kind of confirms what we all kind of think of as conventional wisdom, right? But you know, in most cases, it really proves what our it confirms what our biases are, I guess.
Yeah.
And then I guess I would just add that when we know that we have a county with a very high rate of prenatal tobacco use, and we don't have the demographics on those people that responded in a given year, you know, like the percentage of births or the mother smoked during pregnancy, we don't know the demographics. We don't know how that, you know, we don't know that. But when we look among the general population, like we can look at women in an age group, and we can look at the tobacco use rates by income or education level, and that gives us a pretty good clue of where we're going to target prevention efforts.
Yeah, absolutely. So that's awesome, an awesome example of, you know, data to action, how the information can really inform programs and services. Does Alice have any examples of how you have kind of facilitated the process of looking at data with partners? Let that question go for today, and move on from here. But thank you both for sharing your experiences and some of the wisdom that you've gained through those experiences. So to close today, we have a couple of additional notes and reminders to share. So as we've said, we'll be providing you with 2 spreadsheets and some supplemental data and resources to complete this health status assessment. As a reminder, there's a couple things for you to search for on your own, such as the data that are available through the MyFi. And those indicators will be highlighted in yellow. As we've said also, we are still waiting for some data points to come through. So we're trying to balance, we send this out with how many gaps we're sending it out with. So want to send it out in a timely way. So it may be the case that you get some additional data after the fact. After we send the spreadsheets, we may send a couple more data points to fill in if we don't have those by early next week to stick in the spreadsheets. If you need any support or help interpreting the data that you have in front of you, or thinking through a process for reviewing it, or coming up with a plan to review it with your partners, or, you know, we send it to you, like, what is this? This is crazy and overwhelming. We want you to sit with that feeling. Please just give us a call, and we are more than happy to kind of talk through with you what you're looking at, what we notice when we look at the data, some of the points that we might pull out, you know, based on our perspective. We're so happy to talk with you about that and to support you through the process. We don't want you to feel overwhelmed or like it's impossible, any of that. So if you're feeling that way, just send us an email, give us a call, and we are more than happy to talk you through it. it.
I'd like to add that I know, like I, for example, love data, but everybody shares my passion, and so that's true local health departments as well. So this webinar, if you don't like data, this could have been a laborious time with us, but if you love data, you are probably thinking that you're getting a Christmas present with the data sheets and the data that we're going to send to you. So if you're one of those people that just can't stand data and you don't have help at your health department through an epidemiologist or somebody that shares our love for data, please take us up on this technical assistance offer. We just don't want the data to feel overwhelming to you, and data going to program action is really an exciting thing. So please shout if you feel well.
Thank you. So we certainly couldn't leave this conversation without, I wish there was like a sound effect for this, without thanking our partners at MDHHS Epidemiology for providing just a tremendous amount of data and doing the tremendous thinking that they did to get to the point where they could provide that data. I know it was a big lift for them, and we're very grateful for the work that they put into pulling this all together. We do know that as you dive in and begin looking at these indicators, you'll have questions about the data source, how it was pulled, what it means. Please direct your questions our way to either Lauren or Trudy or Robin, and we'll either answer those questions directly or we will get answers for you from the EPI staff. We're trying to be super efficient with their time because they have given us a tremendous amount of time for this already.
And again, in addition to thanking our MCH epidemiology staff, I want to thank my colleagues that are in the room from MPHI, because they took all the wonderful data that our epidemiology colleagues sent to us, and they sent it to us in like multiple individual documents. And so all our colleagues in the room, Julia, Aaron, and Lauren, had to pull them together into these state documents and then local documents so that it was sensible. And they did such a good job color coding it and tabbing it and really being thoughtful about how the data might be best shared with you. So we have lots of kudos to give to our colleagues in the room as well.
Thank you. It's definitely been a joint process getting to the point where we can share these data, and we're